So good morning. Welcome to the second day of the AS meeting. First, we have the session of 4, immediately followed by the MCW Stuart Wilson Historical Lecture with Dr. Pasica. And at this time, I would like to welcome our moderators, Dr. Doherty and Dr. Baragamian. And let's start our session.
Right, good morning. Our first speaker is Florence Bion from University of Lorraine-Nancy, and she will be presenting intraoperative hemodynamic instability during laparoscopic adrenalectomy for pheochromocytoma without preoperative medical preparation versus non-secreting tumors.
It's here? Okay. Good morning, everybody. I'm Dr. Florence Behane, a general resident from France, and I would like to thank the AES meeting for allowing me to present our work on intraoperative hemodynamic instability during surgery in non-prep pheo versus non-secreting tumor patients. We have nothing to disclose. Current guidelines recommend to control hemodynamic features during surgery in pheo patients to minimize perioperative complications. However, in current studies, there is a lack of collected prospective hemodynamic data during surgery in pheo patients. Also, intraoperative hemodynamic instability has been observed in other indications than pheo patients. But most importantly, there's a lack of agreement in current studies concerning the definition of intraoperative hemodynamic instability. A Dutch group recently created and validated a hemodynamic instability score using 3 intraoperative components. Of course, they used hemodynamic values such as blood pressure and heart rate, but also they used 2 other components reflecting the anesthesiologist intervention: the use of fluid therapy and the use of vasoactive drugs. Each component is scored separately according to a scale reflecting the deviation from predefined thresholds. Each hemodynamic criteria has an actual value and a time-weighted adjusted value. So for example, if we use the component maximum heart rate, if the patient during surgery has a maximum heart rate of 112, he will score 1. And if this maximum heart rate lasted for 0.2% of the intervention, he will also score 1. You addition all the different scores and you get a single score ranging from 0 to 160. To establish the HIA score, they used what was considered as low-risk surgery, such as VATS, and high-risk surgery, such as PPPD. This is why we wanted to use this validated hemodynamic instability score and compare it during unilateral surgery in pheo patients versus non-secreting tumor patients. We included all consecutive patients who underwent surgery in our center by the same surgeon from September 2015 to August 2019. We excluded 150 patients, and specifically we excluded 11 pheo patients, 5 because they were operated by another surgeon, 2 because of lack of collected data, 2 because they benefit from partial adrenalectomy, 1 because the patient was in the ICU before surgery, and 1 because he benefited from laparotomy. In total, 60 patients were included in our study, 30 in the pheo group and 30 in the non-secreting tumor patients. We did not specifically prepare our pheo patients before surgery. However, we did continue long-term antihypertensive medications in both groups. Concerning our data collection, we prospectively collected every 20 seconds using the Vital Capture software intraoperative data, such as systolic blood pressure, diastolic blood pressure, mean arterial pressure, and heart rate. We divided our study into 2 periods: total procedure time, from induction of anesthesia to OR discharge, and incision to closure, from skin incision and to skin closure. Concerning our patient's characteristic, there was no significant difference in terms of age, sex, BMI, blood pressure before induction, long-term antihypertensive drugs, and tumor size. As expected, there was a significant difference concerning the pre-op cadmium ratio with a higher rate in the pheo patient. Here is a representation of the systolic blood pressure captured every 20 seconds during surgery. In the red, the pheo patients, and in the blue, the non-secreting tumor patients. We smooth the data and you get the figure on the bottom half of the slide. Interestingly, it seems like both groups seem to have the same wave pattern during surgery, with the highest systolic blood pressure at induction that decreases to rise again just before the ligation of the vein. We specifically analyzed the hypertensive criteria of the HI score. And in the total procedure time, duration of heart rate superior to 100 beats per minute and systolic blood pressure superior to 160 was significantly higher in the Theo group. This was also the case in the second period. When analyzing the hypotensive criteria, in the total procedure time, there was no significant difference between both groups. This was also the case in the incision to closure period. And when analyzing the anesthetologist intervention components, fluid therapy, norepinephrine, and other vasodilator was significantly higher in the Theo group. This was also the case in the incision to closure period. And when you sum up all the different components, you get the total HIE score. In the total procedure time, the HIE score was significantly higher in the Theo group. It was 33 versus 20. This was also the case in the incision to closure period. Here are the violent plots representing the number of patients according to their HIE score. In the multivariable analysis, what remained an independent factor of a HIE score superior to 33 was pheochromocytoma with odds ratio of 9.9. Long-term antihypertensive medication and blood pressure before induction had no impact on the HIE score. This study was a highly accurate assessment of intraoperative hemodynamic features during surgery. We showed that there were more hypertensive episodes in non-PrEP Theo. We also showed there was no difference in terms of hypertensive episodes between Theo patients without preparation and non-secreting tumor. Blood pressure before induction had no impact on the HIE score. The strength of the HIE score is that it takes into account not only the intraoperative blood pressure, but also the intervention from the anesthetologist team. It's a relevant clinical tool to compare different data sets. So according to the HIE score, both groups, non-PrEP Theo and non-secreting tumor patients, could be categorized in the low-risk surgery. We acknowledge that we cannot do a head-to-head comparison, but when analyzing the HIE score in pheochromocytoma patients in the literature, PrEP Theo seemed to have a higher HIE score. We acknowledge that our study was a small number of patients, and it was an observational study with unaccounted biases. We also acknowledge that this study was not designed to assess the usefulness of medical preparation before surgery in Theo patients. To conclude, this study was a highly accurate representation of hemodynamic profile during surgery in Theo patients and non-secreting tumor patients. Median HIE score was low in non-PrEP Theo. These data highlight the need to better understand the role of medical preparation in Theo patients. Thank you for your attention.
Thank you, Dr. Bihan. Thank you, Dr. Bihan. The floor is open for questions. Would you please state your name and your home institution?
Hi, good morning. Matinees, Boston. Could you tell us a little bit about how you communicate with your anesthesiologist? And do you have kind of a homogeneous group or a core team of people that you work with? Sometimes at big institutions, there's a variety of folks. And how do you ensure that you get that team? Thank you.
Well, thank you for the question. So we are a regional hospital from Nancy, specialized in the endocrine surgery department. For the study, 16 anesthesiologists were intervened, including a resident anesthesiologist that rotate in vascular, general surgery, cardiothoracic. They are not specialized in endocrine surgery. And it rotates all the time, so we do not specifically communicate with our anesthesiologist.
Thank you.
Next question on the left.
Good morning. Vanessa Lindeman from UAB in Alabama. I apologize if you included these data already, but I wanted to ask if you noted any difference or did any further sub-analysis based on the degree of catecholamine elevation in pheochromocytoma patients. In my experience, there are some patients where the catecholamines are multiple times the upward limit of normal, upwards of 10 times, and those patients behave differently intraoperatively with manipulation of the tumor versus patients with milder degrees of catecholamine secretion.
A very good question. We did not analyze the HIE score according to their catecholamine ratio, so I cannot answer to that question, but we should. We will.
Thank you. A very nicely presented study. Great work. Thank you.
Thank you.
Next question on the left.
Hi, Barb Miller, Columbus, Ohio. I haven't had my coffee yet this morning, so I'm not sure if anything's going to make sense. Nicely presented study. I would say that your conclusion of being a highly accurate assessment is probably an overcall. I think there are an incredible number of unknowns in this. I did notice on the figure that you showed of the different time points, which was interesting to watch in terms of vein ligation. You didn't have any of the blood pressures listed on there at least that I could see. So the question is, where were the blood pressures? How high were they? How low were they? A lot of that, the low blood pressures are expectations, but I think to get to Dr. Naze's point is that there's so much variability in the anesthesia teams, and we hear from Dr. Valls, who works, with the same anesthesiologist all the time. They can do things that we cannot do here in the United States. I'm trying to give my anesthesiologist not to give norepi while I'm dissecting around the tumor. And the question is, we started out with a mortality rate of about 50% in these patients. So going back to saying we don't need to do anything, I think is a dangerous statement. Anesthesia has improved much over the years, but we still have a long way to go. The question is, are the anesthesiologists actually doing what they're supposed to be doing, right? So, where are those excursions? Are they allowing the patient to kind of wake up in the middle of the case? Is that the reason for their excursion in the blood pressure? Because that happens to us where, the cavity, compresses and you're like, is the patient completely paralyzed, that sort of thing. So there's all kinds of unknowns. So how do you account for that in this?
Okay, so we are not saying that we just wanted to share our experience on not preparing FEO patients. All patients had a deep block induction that was monitored with a BIS. So both groups were comparable in terms of the anesthesiologist deep block induction. What was the question? I'm sorry. Can you repeat? Sorry.
Yeah, my question is, how do you account for the variability, right? So you may have gotten through, it's like with any other operation, you may have gotten through the operation, but did you do it as well and as safely as possible, right? Were the excursions, could they have been handled better where you didn't have those excursions or those low points, that sort of thing? So could the patients have been treated better?
Probably, because it is an observational study with some biases, and we cannot control the anesthesiologist biases because we had so many different anesthesiologists, so probably.
Dr. Du, last question, please.
Guang Du, San Francisco. Just a short question. A very nice presentation. I'm always impressed that we're educated by people from outside of the United States, and especially the European group and sometimes the Asian groups, about how to do something differently. And, we are learning now that in some patients, you can do your pheochromocytoma without prepping. And that's been a dogma forever. The question I have, and you've shown that you can do them safely. The question I have for you is, how do you select these patients? If you're given 100 pheos, how many are prepped and how many are not prepped? And how do you make these decisions? The endocrinologists make those decisions, the anesthesiologists make the decisions. Obviously, some of them are safe. You can do that.
So actually, we did not select all the stable patients, the patients who are not in the ICU and are all non-prepped. We do not select our FEO patients. And the decision-making is from the surgeon.
So the patient that came in prepped by whoever decided to prep them, you kept them prepped.
No one is prepped in our center.
Nobody's
We
prepped.
only continue nobody's prepped. Stable patients are not prepped. We only continue long-term antihypertensive, and this is since 2015. We do not prep FEO patients.
So you did not study anybody who
I have
has
never.
been prepped.
I'm a resident, and I have never seen a prepped FEO in our center yet.
Very interesting.
Yeah.
Thank you, Dr. Bion.
The second paper of our session will be presented by Dr. Mark Cohen, Novel Repurposing of Sulfasalazine for Improved Treatment of Adrenocortical Carcinoma through the SLC7A11 XCT INC RNA OIP5AS1 network pathway. Did I get that right?
Sounds good to me. All right, thank you, Dr. Doherty and Dr. Bergamian. It's hard to believe it's been 27 years since my first AAES presentation back when I was 5 years old, but it's a real privilege to be here at the podium again. I thank the program committee. I'm presenting on behalf of Dr. Subramanian, who's unable to attend today. So as we all know, ACC carries a pretty poor prognosis, especially since many patients present with advanced disease. And when you look at 5-year survival, even for stage 3, we're looking at less than 40% survival at 5 years. So what we wanted to do was, what we know is that as tumors progress to metastatic cancer, their metabolic properties also change. And so when we look at how to think about identifying some new markers, we want to look at therapeutic strategies where targeting metabolism may give us an opportunity to look for new prognostic and diagnostic markers. We analyzed metabolic genes and transporters differentially regulated between primary and metastatic ACCs, and we looked at 4 data sets of primary tumors and 2 of metastatic tumors, comparing those with normal adrenals, where we found 25 genes were significantly upregulated and 93 were significantly downregulated, and that was out of a data set of 3,507 metabolism-related genes. We then did a DAVID analysis, which is a database for annotation, visualization, and integrated discovery to identify pathways such as the SLC transport mechanism and glutathione metabolism, which were the most upregulated, as well as steroidogenesis and lipid metabolism. We then put these into a correlation analysis of the genes in the GEPIA, which is a gene expression profiling interactive analysis, and identified that the cysteine glutamate transporter SLC7A11 upregulated was seen to be correlated with upregulation in all of those pathways. Now, interestingly, there is an inhibitor commercially available for this particular transporter called sulfasalazine, which has been approved for treatment of IBD and arthritis. We then did some RNA analysis to look at comparing data sets, the TCGA and the GTEx, to look at gene expression, differentiation, and survival analysis in patients with ACC, looking at expression levels and hazard ratios and survival curves to determine what microRNAs and long non-coding RNAs were associated with this particular pathway. We use the MIR system as well as a few other databases to basically look at what's this linkage between microRNAs, long non-coding RNAs. And then we did in vitro testing of this inhibitor, specifically in ACC validated cell lines, to look at cell viability, to look at changes in what's the mechanism of cell death, as well as analysis of steroidogenesis pathways, and finally mass spec to look at lipid profiling. So when we looked at expression levels of this particular transporter in ACCs, we see that it is highly expressed in ACCs compared to normal adrenal tissue. And then when you look at within ACC populations, if it's highly expressed versus low expression, there is a significant change in survival, both disease-free and overall survival. We then looked at the effect of this inhibitor of this transporter using a simple cell titer glow to look at cell proliferation. And what you can see here is that the IC50 concentrations for inhibition are in the mid-micromolar range, between 400 and 800 micromolar after 72 hours, which is a therapeutic level seen with this inhibitor in IBD. We also looked at the induction of lipid peroxidation, which is done through this C11 Butterpie assay, where you can see a color change with lipid peroxidation from red to green. And the top panels are the controls, and the bottom panels are the treated cells. And you can see here there is evidence of lipid peroxidation. We then looked at the mechanism of cell death, and what we were able to show here is that looking first for apoptosis and autophagy, we can see that there's induction of PARP cleavage even at IC50 concentrations in the mid-micromolar range, as well as induction of LC32. We specifically looked at the AKT, MEK, NF-kappa B pathway, and we're able to show induction of both the phospho-AKT as well as several other markers in this pathway that were upregulated, downregulated, and stable. We then finally did a mass spec analysis looking at the lipid profiling of these particular cells with treatment. And here, this is a volcano plot on the top, looking at the total number of lipids on the left and lipids that were oxidized on the right. And you can see over 140 lipids were upregulated, of which 70 were oxidized. Similarly, 42 were downregulated, of which 23 were oxidized. And when you look at the species of oxidized lipids that were most upregulated, we see phosphatidyl enolamine ceramides, as well as oxidized phosphatidylcholines, followed by sphingomyelins and sterols. Looking at steroidogenesis specifically, we see that with this inhibitor treatment, we get upregulation of several of the CYPs, including downregulation of CYP-A11. And then lastly, when we look at kind of an understanding of the different microRNA and long non-coding RNA pathways, specifically in this sequence, what we saw is that the microRNA HSA-MI92A3P is one that's significantly downregulated in ACCs compared to normals. And then looking at its corresponding long non-coding RNA, which is the OIP5AS1, we see that when it's highly expressed in ACCs, it definitely correlates with a lower disease-free and overall survival. And here's this kind of mapped out pathway comparing these that could be a very important pathway to further look at with ACC. So in summary, upregulation of this transporter SLC7A11 is associated with poor survival in ACC, and that the inhibitor sulfasalazine reduces viability in ACC cells. It also induces lipid peroxidation and cell death and reduction of expression levels of the transporter. This lipid metabolic profiling revealed that there were upregulated lipids mainly in the classes noted there, and that treatment with sulfasalazine upregulated several of the steroidogenic enzymes in adrenal cancers. This pathway, therefore, we feel is potential for having a critical role in ACC, but this is very early data, and the limitation of the study is certainly that this in vitro data needs to be validated further to see if this can be repurposed as an adjunct treatment for ACC. Thank you, and happy to take any questions.
Thank you, Mark. This paper is now open for discussion.
Hi, Priya Dediya, Ohio State University. So that's really interesting data, and especially now we're understanding a lot more about metabolomics and an important role that they play in so many cancers. I'm curious, first of all, did you look at actual cortisol production or other hormonal production with treatment with the drug? And then that's my first question. And then my second question is, did you look at metabolomic pathways and specifically this gene as well in terms of mitotane treatment, like patients that have been treated with mitotane and without treatment of mitotane?
Yeah, those are both great questions, Priya. Thank you. So the answer to both is not yet at this time. But one of the things that I think is really going to be important is understanding as we continue to translate those findings a little bit more to understand where the synergies could be, whether we could use this, if this is more beneficial for patients who are naive to mitotane or patients who have had mitotane. if this can be synergized with other drugs that we typically use for standard treatment of ACC, such as cisplatin and other cytotoxics. So definitely studies we plan to do. Thank you.
Dr. Nays?
Matt Nays, Boston. Dr. Cohen, thanks so much. A lot of data. Did you look at total cellular oxidative stress as a contributing mechanism to this? Sulfasalazine as an anti-inflammatory, and oxidative stress as driving a lot of malignancy of this kind. So did you look at that as a mechanism in addition to lipid peroxidation?
Yeah, so we're doing those studies right now, actually, and also comparing it with several normal non-malignant cell lines to look at the effect of reactive oxygen species or oxidative stress in this pathway, especially if ferroptosis is really going to be a potential mechanism of cell death. So from what the early studies that we've done in the last couple of weeks, what I can say is it looks like there is a differential selectivity for ACC cells compared to normal cells. And other types of cancers. So I think there is a real mechanism there. We still need to do a few more studies to really elucidate that, though. Thank you.
Dr. Demure?
Mark, thank you for really elegant work. I appreciate you presenting it. Just wondered, sulfasalazine's been looked at other cancers, like notably colorectal cancer, and how you put your data in context with the findings in, cancers where it's been studied more. And then perhaps, can you dissect it out? Is it really, it's an anti-inflammatory, so is this really an effect on inflammation in general?
Yeah, so that's a really great point. And I think that one of the things that we're really wanting to understand is certainly this is not going to be a single agent therapy for ACC, but the real question is does the anti-inflammatory effect and some of the oxidative effect synergize with other treatments where we can potentially lower toxicity dosing and really create a combination effect that's going to be produce more outcome generated effects. So I think the plan in the lab right now is we are going to be looking at it in a number of different other cancers comparatively to see if there's selectivity for ACC specifically in this regard. And then the fact that it also has this effect on steroidogenic enzymes is also something that was not seen in colorectal tumors. So I think there is an opportunity here in ACC that we can explore further.
Thank you very much.
Our next speaker is William McDonald from Ohio State University, presenting staining patterns of aldosterone synthase in patients undergoing surgery for primary aldosteronism.
All right, thank you. My name is William. Thank you for the opportunity to present our work. I actually started this project with my mentor, Dr. Miller, when I was a student at Ohio State, and now I'm currently a pathology intern at the same institution. So I'm excited for the next 10 minutes or so. We all get to be pathologists together, so we'd have no disclosures. So our understanding of primary aldosteronism has changed significantly over the years. A major change in the way that we report outcomes occurred with the PASO group publication in 2016, establishing new definitions for biochemical and clinical cure. These definitions led to a change in our understanding, recognition that cure rates for adrenalectomy after unilateral, for patients with unilateral primary aldosteronism, not nearly as high as we once thought they were. In addition, we've seen in the literature multiple examples of discordance between imaging and AVS findings, as well as incomplete or absent cure despite lateralization by AVS, as highlighted by this journal article on hypertension. As we've developed our understanding, we've also made further advancements in pathology examination, specifically using IHC techniques to stain for aldosterone synthase, which is an 11-beta hydroxylase in the zona glomerulosa. 2021, International Group of Pathologists released criteria for nomenclature for staining patterns of discrete elements autonomously producing aldosterone, and also recommended the incorporation of aldosterone synthase IHC into routine pathology examination. How patient outcomes after unilateral adrenalectomy are impacted by staining patterns of aldosterone synthase is not well described, and there's no widespread system of categorization for describing these patterns. So our goal was to identify different staying patterns, develop a formal system of categorization, both to promote consistency in reporting as well as promote future research collaboration. We also want to investigate different staying patterns and their impact on clinical and biochemical outcomes. We hypothesized that multiple staying patterns would be noted in clinical and biochemical outcomes after adrenalectomy are impacted by different staying patterns. Performed a retrospective study of adult patients. ABS was performed in all patients except for those with a growing nodule or cortisol co-secretion. All patients were noted to have evidence of unilateral disease. Following surgery, we underwent pathologic examination with both H&E and IHC staining. 43 patients were included with a median age of 50. Mean adenoma size was 2 centimeters. All patients had at least one set of data. Here we have preoperative, postoperative, as well as change in biochemical data. Here we see the total change in aldosterone was about 45. We had a decrease in mean arterial pressure of 13.7 with a corresponding decrease in WHO-defined daily antihypertensive dose of 2.99. Biochemical response was noted in 86%, clinical response in 23%, but 10 had both complete biochemical and clinical response. Here we have examples of different staying patterns that we observed. We had adenomas of varying intensity, some with partial or inconsistent staining. We had micronodules that occurred singly or multiple nodules. We observed a combination of different types. We observed diffuse hyperplasia, as well as one aldosterone-producing adrenocortical carcinoma, and one with no staining. We know from other studies that about 10% of adenomas visible on imaging do not stain for aldosterone synthase, which is why ABS is important for surgical decision-making. In our cohort, four patients, or 9.3%, that had adenomas visible on imaging did not stain for aldosterone synthase, but they did have staining in nodules or micronodules elsewhere in the gland. I'm now going to go through our system of categorization that we developed. We came up with 7 categories, including one other category, in case in the future we identify other staying patterns. We came up with different subcategories for partial staining and different types of combinations so that we may better understand these in the future. Each staying pattern has a description as well as representative H&E and IHC staining. Column on the right is how our current cohort of patients aligns with these categories and the rates of cure, both clinical and biochemical. In terms of association between staying patterns, we weren't able to identify any correlation with outcomes at this time. However, these short-term data may not reflect associations that could be identified with longer-term data. Given the long-standing debate about the need for ABS in those under age 40, staying patterns were examined and compared by patient decade of age. Surprisingly high percentage of patients, 44% in those under the age of 40, were known to have multifocal staining in the form of micronodules and nodules less than 1 centimeter. This may suggest that something else is going on in the contralateral gland and certainly warrants further investigation. One other takeaway from our study was that in evaluating early outcomes, 63% of patients with more than one postoperative biochemical assessment had a rise in aldosterone. You can see in this figure on the left, there's an initial decrease in aldosterone followed by a slight increase at 6 months. The study identified several important findings. These include the variability in how discrete elements combine together, plus unique findings of partial staining or staining of different intensity. It's critical to follow the clinical and biochemical outcomes out for at least 9 to 12 months before reporting what type of cure was experienced. And caution should be taken in those under age 40. Partial adrenalectomy may be best avoided for primary aldosteronism, at least for now, until further studies can be pursued. A new avenue of investigation and certainly some limitations. This was a small cohort, although large for this type of study. Mean follow-up was short, even though some patients were followed for 7 years. However, it's important to have both short and long-term outcomes to begin to understand these associations that may occur. Also, we aren't sure if there's a critical mass of aldosterone-producing cells that will lead to clinically relevant disease. So with these limitations in mind, along with the results of this study and the new questions it's generated, we identified a few next steps: dissemination of the HIST-ALDO consensus criteria, training for pathologists for consistent interpretation, as well as longer-term and larger multi-institutional studies. Conclusion, we found that there are multiple aldosterone synthase staining patterns. Those under age 40 had a surprisingly high frequency of staying outside of a dominant nodule. Larger and longer term studies will be needed to understand the associations between staying patterns and outcomes. And to facilitate this, a uniform system of categorization of staying patterns will be necessary. And we believe that what we presented here today will be a good start. So thank you. I'm happy to answer any questions that anyone has.
Please go ahead.
Hi, Rich Hoden from Boston. Thanks for presentation and kind of, as you suggested, kind of starting us off on this, because I think a lot of us are a little bit unclear as to what to do with the staining, both in aldosteronoma patients and other patients, you know, when you see these results. The thing I'm curious about, these were all hyperaldo patients that you, in this series, right? But
yes.
Unless I misunderstood, the renin levels did not seem to be very suppressed. Like the average was 3 point something. Is it?
Something.
Is it?
Yeah, so that's a good point. I think in our study, there are, like, the mean renin level may not reflect necessarily the overall population. Like, each patient was kind of handled on a case-by-case basis with their unique factors that go into interpreting the adrenal vein sampling results. So these were discussed with the group and at tumor board, and all of them were determined by the clinical team to have unilateral disease.
So it's a different assay. Thank you.
Next question.
Morning, Naresh Nilabo, NCI, Bethesda, Maryland. Excellent study. I think in 2024, you know, the aldosterone synthase is your end product of the synthesis, but I think, and I wonder if you looked into the mutations related to these tumors, there are different patterns. KCNJ5 is one thing, calcium channel is another, or ATP-related mutations, because that might dictate why your staining is so different in the outcome and such.
Yeah, that's a good point. And there have been studies that have kind of highlighted that different staying patterns may be due to different mutations. So yeah, I think that's a good point. And we may see further developments in the future in that regard.
Yeah, I think that's Quang Du from San Francisco. I have two questions. My first question's already been asked. I think you obviously want to look at the somatic mutations of these nodules and, or even the micronodule to understand the different staining and potentially see where you can see any difference clinically. My question for you is that have anybody correlated these types of staining pattern with metamidate scanning? I know we don't do them here, but probably soon enough we'll be doing them for deciding whether or not which side to remove.
Yeah, that's definitely a good point. I myself am not super familiar with that, but it does seem, it seems like a good further evidence study. Thank you.
Matt Nays, Boston. Excellent study. I only come here with a comment, and that comment is that CYP11B2 staining has revolutionized our understanding of this disease. My clinical partner, our clinical partner, Anand Vaidya, has helped our understanding of this multifocality. And the reason that matters for us as surgeons is maybe not because of the specific mutation down to the gene level, but in what we do for the patients and how we counsel them in the clinic. So in the last year, I've had 2 patients who have primary aldo unequivocally, and an adrenal nodule, and a contralateral normal gland. And we kind of debate the pros and cons and the merits of AVS, and we get it. And 2 patients in the last year have lateralized to the other side and has cured their disease. And they have diffuse micronodular CYP11B2 staining and nothing on the contralateral or at least the disease has been cured. And so from my perspective, it really pushes me to want to get AVS in virtually everybody, because I've seen almost every one of those staining patterns. Thank you so much.
Yeah, thank you for the comment.
Thank you.
So the fourth and final paper for our session this morning is being presented by Christopher Karnabatu on behalf of the UT Southwestern Group, Avoidable Biopsies Validating Artificial Intelligence-Based Decision Support Software in Indeterminate Thyroid Nodules.
All right. Good morning, everyone. My name is Chris Karnabatu. I'm the Endocrine Surgery Fellow here at UT Southwestern, and I'd like to thank the AAES for allowing us to present our work today. So, we have no relevant disclosures to discuss. Cytologically indeterminate thyroid nodules remain a diagnostic dilemma despite advances in molecular testing. And ultrasound serves as an excellent opportunity to potentially further risk stratify these nodules. And furthermore, multiple AI systems have been developed and even FDA approved to aid in this quest, which serves as exciting territory to do our research. And so what we ended up doing is we examined the performance of one such system, KIOS-DS, in its ability to risk stratify these indeterminate thyroid nodules. And the KIOS platform does this by two different and independent components. It has the automated TI-RADS calculator, which functions much as how a radiologist would in terms of assessing thyroid nodules using the ACR TI-RADS descriptors. It also has an AI adapter, which what it does is uses deep learning technology to further risk modify that TI-RADS level into a new level, potentially. And so here what I want to represent is a graphical user interface of how the KIOS system works when the radiologist inputs two orthogonal views of the thyroid nodule, both longitudinal and transverse. And you can see that the thyroid nodule is selected by the radiologist. And so what KIOS does is the automated TI-RADS calculator that I mentioned earlier uses those descriptors to assign points, and then the the AI adapter further risk stratifies and adds or subtracts points to come up with what we see in the top screen as a final TI-RADS level. And so now that we've reviewed some of the basics of what KIOS does and some of the fundamentals, what exactly was the aim of our study? Well, we wanted to assess the concordance of the KIOS automated calculator with the radiologist-derived levels. We also wanted to understand how does the AI adapter perform as a malignancy classifier, and then taking all of that information into account, we wanted to see and explore what are the clinical ramifications of this. And so in terms of how we approached this, we identified a population of a large number of patients between 2018 and 2023 who underwent thyroidectomy. We had the inclusion criteria that follow the Bethesda 3-4 cytology, ultrasound studies with archived images at our institution, radiologist impressions as well as the TI-RADS level, and the final surgical pathology, which served as ground truth. Now, looking at outcomes, the automated calculator was benchmarked against the radiologist-derived TI-RADS levels, and the AI adapter performance was also assessed against radiologist-derived levels as a malignancy classifier, and those performance metrics that we looked at were the AUC, the sensitivity, specificity, negative and positive predictive value. And finally, biopsy thresholds were reevaluated by applying the standard TI-RADS management criteria based on the nodule size of those thyroid nodules. And so we identified a total of 28 indeterminate thyroid nodules meeting our criteria. Of these, 7 were found to be malignant, while the remainder were benign. And this table summarizes the demographics, which were largely similar between both cohorts, with the exception of some discrepancy in gender as noted by that red box. Now, all 7 thyroid nodules in the malignant group were classified as suspicious on molecular testing, whereas 20 were suspicious in the benign group. Patients in the malignant group underwent total thyroidectomy in 71% of cases, while the benign group was managed with total thyroidectomy in 43% of cases. So this figure here shows the distribution of TIRADS levels for both malignant and benign pathologies. And these are classified by radiologist at the top, and then the automated TIRADS calculator at the bottom. And I want to point everyone's attention to how there's some similarity in terms of the distribution of the TIRADS levels and overlap. And so we tried to quantify this using the Cohen-Kappa statistic. And so looking at all thyroid nodules, whenever we're comparing the TIRADS calculated to the radiologist-derived levels, we arrived at a kappa of 0.25, or fair agreement. And when we broke that up by surgical outcome, you'll see that for the malignant group, we had a kappa of 0.36, still fair agreement. And in the benign group, a kappa of 0.18, or slight agreement, was observed. And so this histogram here we have on screen left, the radiologist-derived TIRADS levels for both malignant and benign thyroid nodules. And on screen right, we have that other independent AI adapter, so not to be confused with the automated TIRADS calculator, to see how it performed as a malignancy classifier. And an interesting takeaway here is how there's a lot of overlap in the radiologist-derived TIRADS levels. However, there seems to be a bit more separation in the AI adapter. And we can kind of see that around TIRADS 4 is where we have an optimal separation between the benign and malignant subgroups. And so we took that information and plotted an ROC curve and see that the radiologist-derived TIRADS level had an AUC of 0.71, while the AI adapter had an AUC of 0.86. And looking at that optimized threshold that I was describing earlier in that histogram, what we see is that we have a large improvement in specificity for just a small cost in sensitivity. And so how do we translate that clinically? Well, what we did is we took a look at separating malignant and benign pathologies, and we see that the Kios AI adapter would recommend 6 of 7 biopsy criteria for the thyroid nodules in the malignant group, and we saw an 81% drop in the benign group. And here, that one nodule that did not meet biopsy criteria after the new TIRADS assessment by the AI adapter turned out to be a 1.2 centimeter PTC. And so, to our knowledge, this is the first study assessing the performance of Kios DS to specifically risk stratify indeterminate thyroid nodules. Our findings suggest that Kios DS's performance in predicting TIRADS levels for indeterminate thyroid nodules is comparable to that of an experienced radiologist. The AI adapter improves upon radiologist-derived TIRADS performance as a malignancy classifier in indeterminate thyroid nodules. And furthermore, the use of the AI adapter may decrease the number of biopsies that would ultimately result as cytologically indeterminate. So some limitations include retrospective analysis, small sample size, variability in imaging acquisition, as well as heterogeneity in ultrasound equipment and quality, as well as surgical decision-making, which wasn't necessarily influenced by cytologic indeterminants, but perhaps may have been because of patient factors such as compressive symptoms. And so some future directions include comparing Kios DS with molecular testing to identify areas of complementary use, as well as assessing malignancy prediction for differentiated thyroid cancer subtypes to better understand how Kios AI works. I thank you so much for your time. I want to thank my group listed here. Welcome to Dallas, and I welcome any questions.
Great. So this nicely presented paper is open for discussion. I can't tell who's first over here. Is that Dr. Sturgeon?
It is, yeah. Court Sturgeon, Chicago. I'm blocking Dr. Shaha, so he can't talk. Excellent talk, and we've been doing this at our institution, looking at how AI can augment the ability of radiologists to do their work, not trying to take over their job, but allow them to do things faster or better. 2 questions for you. The first is, have you thought of expanding this into radiologists from multiple institutions that have varied levels of experience with thyroid sonography? And number 2, your correlations I thought were interesting, but what's really important is, does the AI recommend biopsy in exactly the same frequency as the radiologist does, essentially? So more like dichotomizing it, instead of looking at TIRADS 1, 2, 3, 4, 5, does it correlate, but just should it be biopsied or should it not? I think that's a very useful part of it.
Thank you. No, I mean, that's an absolutely excellent point and something that we'd love to do. One of our hopes in doing this study was to inspire more research and validation studies with respect to Kios, because we recognize that we're just scratching the surface here, and this is a lot of uncharted territory. And so we're pretty excited to see if there are other radiologists, other institutions that we could potentially work with and assess how do radiologists and use Kios to be more accurate and more efficient, and how does Kios stack up perhaps as a malignancy classifier just going forward?
Tony Bettinato, New Brunswick, New Jersey. Thank you for your presentation. A question I have is, in your 7 malignant nodules, you didn't say which were papillary and which were follicular, and I feel like the TIRADS score prioritizes features that we know to be consistent with papillary thyroid cancers, whereas follicular thyroid cancers can look quite bland on ultrasound. So was there any difference in performance between papillary and follicular thyroid cancers?
Yeah, no, excellent question, a future direction. What we did is we just binarized malignancy versus benign. So I can give you the breakdown that we had. We actually had 5 PTCs, 1 Hürthle cell carcinoma and 1 follicular carcinoma. But that's certainly a potential discussion point going forward, is seeing how that breakdown works when we discuss just looking at PTCs and seeing whether or not that alters Kios' ability to risk stratify or act as a malignancy classifier. But certainly an interesting future direction. Thank you.
Dr. Zeiger?
Martha Zeiger, NCI in Bethesda, Maryland. Nice presentation, fascinating. I think you're probably going to change how we do things in the future. My question is, based upon my just looking at cases that have been biopsied that to me look benign on ultrasound, is have you considered running this test completely agnostically? In other words, just look at thyroid nodules, not stratify them in terms of the different TIRADs, so completely agnostically, and train the model that way? Or in essence, have you already done that with this experiment?
Yeah, I think in essence we have already accomplished that with respect to indeterminate thyroid nodules, but again, there's a lot more room for us to continue doing this kind of research. But if I'm understanding your question correctly, I think that that's something that we've already done with respect to Bethesda 3-4.
What I'm suggesting is consider training it with benign all the way to malignant. I'm just wondering if that would improve the outcome.
Yeah, I mean, I don't have a good answer for that, but that's certainly something we can consider in the future, absolutely.
Dr. Wilhelm.
Scott Wilhelm, Cleveland, really nice. I was driving back from ESU, where I got to meet you, so congratulations on that.
Thank you.
And my driver in the Uber asked me very specifically, because he saw a lot of us as surgeons here, how is AI going to affect the realm of surgery? And we actually had a nice discussion, so maybe he should ask the question, but about, how does AI help us and what's it going to do for surgeons? So you're bringing us something really cool. The technology has been very well applied to chest x-ray, and it actually has been validated pretty well in that field, but one of the initial problems that they saw with it was when they gave AI the same chest x-ray over and over and over again, sometimes it would miss. And because it's contextual and in terms of the learning model. And so I'm curious, how many runs did you do on all of your ultrasounds? Did the AI only look at each ultrasound once, or did you run it through like multiple times and see if it gave you the same answer?
Yeah, no, that's an excellent point. So we just used those 2 orthogonal views once, but one, to kind of extend your question, I think one interesting point to bring out is that Kios actually is just looking at 2 images of an entire thyroid nodule. So you're looking at a 3D structure, and Kios is making all of these decisions based on 2 views. And so what's really interesting and what I surmise Kios is currently working on is, how does that change when we actually look at the entire volumetric analysis of that thyroid nodule? And that's going to be a pretty exciting thing to take a look at and further validate. But thank you for that question.
Dr. Cohen.
Mark Cohen from Urbana-Champaign, Illinois. I want to applaud your group on a wonderful study. This is the start of, I assume, will be many more studies around AI in our field. And people often ask, will AI replace physicians? And the answer is probably not, but physicians who know how to use it are probably going to outperform those who don't in the future. My question is around some of your limitations of your correlation around sample size. What do you think is going to require a sample size to definitively show significance in this space for your assistant?
Absolutely. Yeah, no, so that's an excellent question. This is more of an exploratory study, proof of concept. So we didn't specifically analyze this to see what, or do a power analysis to see exactly how many samples we'd look at, but that's certainly something to consider going forward. It's just inherently a little difficult given the amount of data and the strict inclusion criteria we used, but something that we're going to look at going forward. Thank you for that question, though.
Dr. Carty?
Carty from Pittsburgh. As designed, TI-RADS is imperfect, ATA ultrasound criteria are imperfect, and this is imperfect.
Absolutely.
How do you plan to improve it? And what do you say to the patient? I just want to hear your words.
Absolutely.
Whose cancer you missed.
Great point. And what I would offer to the audience is not so much interpret this as a missed cancer, but rather that Kios DS offered to not necessarily biopsy that nodule at that time, but rather continue surveillance. Because as you very well pointed out, ACR TI-RADS, when we use that, we're the ATA guidelines, we acknowledge very well that we're potentially missing clinically non-significant pathologies just by not biopsying sub-centimeter nodules. And so what Kios DS is saying, at this time, we don't necessarily recommend that you biopsy this nodule, but survey it. And so when it meets that threshold, then biopsy it. But excellent point, thank you so much.
All right, last two quick questions. Dr. Shaha.
I changed my name to Sturgeon, New York, Chicago. How do you integrate the clinical findings in this and the clinician's judgment, which is behind any thyroid nodule or any workup of any disease? And the last is, how do we integrate the patient's psyche? Minimalist or maximalist. I have done biopsies of 5 millimeter nodule because they threatened me that I'll go to Boston and have a biopsy.
Yeah, no, that's an interesting point. So in terms of the biopsy criteria, I think I would kind of go on the last answer that I provided. But no, to answer your first question, we have not yet started looking at how different patient factors influence biopsy thresholds and criteria. But again, that's something that we're super excited to take a look at going forward in the future.
The last question.
Jen Kuo, New York. Thank you for that really exciting and wonderful presentation. So sorry if I missed it, but we all know that AI algorithms are only as good as the training set and how diverse and representative that training set is. So could you clarify how that AI TI-RADS calculator was developed? And then the second question is, do you know the basis for your deep learning algorithm? Is it a forest plot, clustered, and supervised, unsupervised learning, and does Kios try different ones and pick the ones that performed best? How was that developed?
I think you're hitting on a point that we are very hungry to take a look at because Kios just has a white paper and it reports some validation metrics on a generalized group of thyroid nodules, but to answer your question, we have no information on that data set. And so that's something that we'd love to potentially speak with Kios and see if they'd divulge that. But as of now, it's a proprietary data set, so I don't know.
Thank you very much.
Thank you so much, appreciate it.
For all of our presenters. And I think we'll move directly on to the Wilson lecture. Dr. Soros.